like every patient I have has some type of sleep disorder.
Yeah,
Yeah. And
that's pretty much the. I'm just turning up my volume a minute. Pretty much an issue with everyone. We're all sleep deprived.
in some way, shape, or form, but then you get all the other pathological conditions,
Yes.
narcolepsy, right?
Yeah. Yes. Yeah.
Yeah. And a lot of people are looking when someone has narcolepsy, they're having seizure activity.
Yeah. But it's not. It's not seizure at all. It's
It's not a
just
seizure at all. Yeah. So,
what they've been looking at more and more is the orexin issue with orexin um, uh, being deficient. Um, but it's a really odd condition. I
mhm.
remember, just a funny story. When I was in college, and I was always had an interest in magic and sleight of hand and stuff. So I went to this. One of my friends invited me to this local magic club where magicians get together and they show each other stuff, and it's a lot of fun. But one of the magicians there had narcolepsy, and I remember him showing a card trick, and he
Okay.
would be pick a card, and then he just was holding his hands out, and he just went, and then paused for a few moments, and then came back and just continued and picked up as if nothing happened.
Wow. Trained himself to do that, I'm sure.
Yeah, I mean, it's
Huh?
yeah, and I'm sure for these people, it's really a disturbing condition to deal with. I have not worked with any narcoleptic patients. I would welcome the opportunity, certainly, but
Yeah. Yeah, I've had a couple dozen. Yeah.
really,
Yeah. In the brain
is it?
trauma world, you start to see that a lot, right? Um, I mean, I had one patient that had brain trauma, and then he was driving a farm vehicle,
Uh-huh.
and then he had another accident. He does
Wow.
not remember having the second accident, so I believe that he fell asleep.
Yeah.
He fell asleep at the wheel, and then he hit his head again, and then he started having frequent narcoleptic episodes that were like your magician. Um, he'd fall asleep, and then a minute later he'd wake up. He'd fall
Yeah.
asleep, and then woke up. But when we were done with him, he didn't have any narcoleptic issues whatsoever.
Wow. Wow.
So,
So what specifically having dealt with a number of narcoleptics, what do you find is the common thread that helps them the most therapeutically?
well, therapeutically, I've always done like neurofeedback and then
Yeah,
all my other neuro exercises.
sure.
So I just always treat the same thing. I,
Yeah.
I mean, I get as much specificity as I can, treat it,
Mhm.
look at changes, plasticize it, and then the patients are usually fine. Uh,
Mhm.
Now that we've gotten into this post-COVID POTS world, we're seeing people with chronic fatigue. So one of their comorbidities, other than heart rate changes, things like that, um, is fatigue, very heavy fatigue throughout the day, where they have a
Yeah.
hard time getting out of bed. When they do get out of bed, they get dizzy, their heart rate goes up.
Mhm.
Then they're going to have to go sit down or stabilize themselves in some way for the day. Uh,
Yeah.
a lot of teenagers, we're getting a lot of teenagers with the same effect.
Mhm.
So it's really kind of sparked my interest even more than a narcoleptic case because
Yeah.
of this sleep wakeful cycle. Um,
Mhm.
and
Yeah.
The orexin and all these other chemicals are hypothalamic pituitary type of manifestations, which are there's a chemical communication system with the body, but there's also the neurological thalamic communication of sensory input, right?
Yeah, sure.
Yeah. So we're looking at that. And you also have to look at the basal ganglion, how the basal ganglion fits in with the
Mhm.
um, regulating
Yeah,
thalamic input to the brain, too. So,
yeah, absolutely. Because I mean, I would say more cases with sleep issues would be those who have trouble sleeping, sleep onset, sleep maintenance. Those are the ones that I've mainly worked with. And I have found that neurofeedback can be very helpful, of course. But when you talk about insomnia, it's you have to take a really deep dive into the, what is really underpinning that issue. And sometimes it's purely physiological, other times it's an emotional regulation issue. People with, anxiety have trouble sleeping. People who have trouble sleeping eventually get anxiety. So it's a vicious cycle.
yeah,
Yeah.
yeah, right. They have trouble sleeping. A lot of times, even with neuropathy cases,
Hmm.
pain
Yeah,
wakes them up
pain,
at night.
pain to it.
Pain.
That's another thing that interrupts. Yeah,
Yeah, definitely pain. And with neurofeedback, there's a lot we can do with pain, right? Brain
sure.
pain type
Yeah,
of issues,
yeah.
frontal parietal cortex issues too. Um, but then you get a lot of feedback from patients when you really start getting into the sleep thing is their dreams.
Hmm.
Like some of the kids that I've gotten that have had really bad brain traumas have
Uh-huh.
really horrific dreams.
Yeah, sleep
Have these
terrors, night terrors. Yeah.
night terrors and things like that. Yeah, exactly. Um, and so, I started thinking about that and thinking about the dorsal stream and the ventral streams.
Yeah.
And the ventral stream kind of interests me, hitting the temporal points, T5 and
Hmm.
T3, things like that,
Yeah.
um, and stimulating it that way. Because visually, a dream is a visual manifestation of the brain asleep.
Hmm.
So, well, that was my theory.
Yeah. Well,
It
that's
sounded good. Sounded like really educated.
yeah. Well, no, that sounds like a good theory because um, the ventral stream um, is really related to vigilance, and hypervigilance would certainly be a reason for developing sleep
Uh-huh.
problems. So that, totally makes sense to me. Um, but, then you get into these cases that have genetic disorders, which makes it even more challenging because then you got to kind of parse through exactly what is going on. Is it a lack of neurotransmitter, a lack of or a receptor issue, and so on? I had one case that comes in mind. I told you I had, currently working with the MBD5 associated neurodevelopmental order child. And I'm starting to make progress with him, but I'm thinking of another case I was referred to me a number of years ago, several years ago. And she was in her early 50s.
Hmm.
And the chiropractor that referred her to me said that, and when I saw the patient, she confirmed that she had been to a number of clinicians, had transcranial magnetic stimulation, ketamine treatment, talk therapy, um, medications, on and on and on. And she could only get 2 hours of sleep in a
Wow.
24-hour period. And I
Hmm.
didn't believe her at first, but when I looked into all of the histories and everything else, it's exactly what was going on. Um, and so that was tough. And I asked her, "Do you take naps during the day?" No. And that's an important question, as you know, because if people have insomnia, maybe they
Hmm.
have a circadian rhythm disorder that is going to really be affected by taking naps in the daytime, and then it changes their rhythm a bit. Uh,
Uh-huh.
the sleep experts um, they always recommend that if you have to take a nap, do it before 3 o'clock so that you don't upset that normal circadian
Deep
rhythm.
circadian rhythm.
Yeah.
Yeah. Uh-huh.
And then, but this woman, unfortunately, I worked with her for 10 sessions, and she finally got to the point where she was able to sleep for 4.5 hours continuously, which
Wow.
was a big breakthrough.
For her, yeah,
And,
man. She gave it
and I,
importance to
I
that one.
wanted to continue, but her husband didn't want to pay for continued therapy and wanted her to try transcranial magnetic stimulation again. And I don't know. But anyway, the sad part about it is that a couple of months after I saw her last, the referring chiropractor had, you know, called me and said, "Did you hear what happened to so and so?" And I said, "No." And she said, "Well, her 24-year-old daughter came home from college and found her hanging in the closet. So she
Wow.
committed suicide." And so,
Terrible.
when I started looking at her case, and, I got a nice note from her husband, and he said that out of all the doctors that she's seen, she always said you're the only one that gave her any help. I was like, yeah, okay, so why didn't we continue here? But that's another question. As I kind of drilled into this further, I discovered this disorder that I didn't know about, and it's called familial fatal insomnia. And I
Uh-huh.
don't know if you've ever heard of it,
No.
but she fit the description completely. Northern Italian, in the Middle Age, and everything that that this was describing in the research literature. I was like, I bet that's what she had. And unfortunately, there is no cure for it. There's no definitive cure. So some of these insomnia cases, this is why I always take insomnia cases very seriously, because the the more serious ones will be driven to suicide. And that's the scary part of it. But most other people, thankfully, that's rare.
That is an excellent example
Yeah.
of basically what, people are going through. Now, is it due to an injury or is it due to a familial nurturing over time?
Hmm.
Uh, you mentioned anxiety and depression having an effect on it. Um, can anxiety profiles exacerbate it to the point,
Yeah.
and how a family handles anxiety over time um, can result in them having this condition, right?
Yeah.
So, we always go back and forth. Was it nurture? Is it genetic? Was it
Hmm.
nurture? Genetic? Um, we had a autistic kid come in the other day, and we just couldn't do the scan. But it was very interesting how the mother interacted with the child versus the father. The father was very calming, and the
Hmm.
mother exacerbated the anxiety where it was like 100 times worse.
Yeah.
And those interactions, as a as creating habits or plastic negative plasticity that
Hmm.
goes on in the brain. You could see it like very young, happening very young. So the reactivity with a child, teaching them anxiety patterns,
Yeah.
uh, was just, I mean, it was like, I wish I had a videotape of it. And
Yeah, that's such an excellent point because I've seen that in working with ADHD patients. And this one mom in particular that I'm thinking of as you're talking about this. And her daughter was doing well in school, but the mom was kind of driven to make her get all straight A's. You know, she had to get straight A's. She got a B minus on this. And it's like, so what? You know, the kid is doing well. And she's wondering why the daughter snaps at her mom and is you know, a kind of uh, oppositional.
mm,
Um, and you know, and I'm trying to explain to the mom to maybe you need to approach her a little differently.
yeah.
And then again, with this kid, sleep was a problem. So sleep issues can show up as ADHD symptoms. And the literature clearly shows that some of these kids are diagnosed with ADHD when they really have a sleep disorder. Uh, and
Mm,
I had one kid who I do these little sleep screening tests called sleep image. And it's a little ring that they take home and it's pairs with an app, but it gives you FDA
mhm.
cleared clinical grade information. And so I saw on this one kid that he was really there was a red flag for
Uh-huh.
apnea, and I think it was central sleep apnea. So I told the mom, look, he needs to be checked out. And he went for polysomnography, um, sleep study. And it was he had some very, very severe, it was actually obstructive sleep apnea. And he needed intervention because his I think I think he had his adenoids taken out or something, but there was just physically this small collapsed pathway. And you know, so whenever I and after this kid was had a surgery, I heard a couple of months afterwards, the mom wrote me back an email and she said, I can't thank you enough. He is doing fantastic now. He's doing great in school. He's, uh, you know, just his behavior is so much better.
Mhm.
So sleep, you know, the point is that sleep can have so many effects, and some people who are diagnosed with various disorders, anxiety included, really have their roots in sleep. And you know, we should really take sleep as a you know, as a society, we really need to take sleep more seriously because it's probably one of the most important things you can do for your health, other than seeing Dr. Joe. Or me.
Or you, definitely you. Uh,
Oh, but that's,
so,
yeah.
you're totally right about that. All right. So, to go through the same questions like what time do you go to bed? How do you prepare for bed? How long does it take you to go to sleep? How many times you wake up during the night? Do you wake up in the morning refreshed? Right.
Yeah, that's the big
Okay.
question.
They're the big questions, but a lot of times, parents, especially of children, even through their teenage years, they'll snap out. Oh, they sleep great. They get up and then they're asleep all night and they get up in the morning.
Hmm.
And I'm like, well, no, that really doesn't tell us what's going on.
Right.
Yeah.
Yeah, because the parent's not in the room when the kid's sleeping.
Yeah.
Uh, you don't know what's happening with their different stages of sleep. And
Yeah, well, you got four stages, right? The first
yeah,
two are not deep sleep stages.
yeah,
Then you got three, four, then
right.
you got REM. And then
Yeah.
you know you're going to go into REM at some time. So
Hmm.
it's one, two, three, four REM, not one, two REM, not one REM.
Right,
You know,
right. Or skip the slow wave sleep. Slow wave sleep is so important. Um, Stage 3 and 4. That's when your memory is consolidated, your pituitary releases growth hormone. You have the glymphatic system, the garbage disposal of your
yeah.
brain becomes
Uh-huh.
more active during that time. That's when the cleanup and the repair goes on. So it's so very important that they're getting into that slow wave sleep and enough REM sleep. REM generally is the last third of the sleep. And ironically, slow wave sleep is more, those stages appear more in the earlier stages of sleep. But
Hold on for one sec,
yeah,
Doc.
sure.
Yeah, right. I'm sorry. Go ahead.
Yeah, yeah, no. So, this whole thing about sleep cycles and how the brain works and how it regulates is just completely fascinating. It's a subject that I really, really am very intrigued with.
All right. So I'm
Yeah,
going to challenge you, Doc. I know
yeah.
you get challenged all the time, but I think this is probably in my practice and everywhere,
Hmm.
the most important aspect of what we do in the healing process, okay, especially with neurofeedback.
Yeah.
It's really, you just kind of covered it all. You fall asleep and darkness comes over you, right? But
Yes.
behind the scenes,
Hmm.
all these things are happening, right?
Right. Yeah.
The cleanup mechanisms, the taking care of emotional traumas that you may experience during the day or emotional just challenges throughout the day. And we don't give it justice. We don't give it justice. And what I'm going to challenge you to do is with
Yeah.
me together, do it justice,
Yeah.
right? It's like really, let's like mull it over to a point where we have people that are calling us to find out what just is it that with sleep could get me 80% better versus what we're getting now. Okay.
Hmm.
And that's the way I'm feeling about it now. I'm feeling about it. There is a syndrome with narcolepsy called cataplexy. Are you familiar with that one?
Yeah. Yeah.
Okay. So, just like you say, you remember cases, like for me, like I remember cases and I'm like, well, I'm losing my memory, but I remember cases. These people become part of you and you remember these cases. So, we just had a girl that had a spinal cord injury from a basketball being thrown in her face. So, the lower part of her brainstem and the upper spinal cord were injured. She was passing out all the time.
Mm.
So they gave her a diagnosis of
Movement disorder
functional mental, yeah,
or functional neurological disorder.
a functional neurological disorder,
Yeah.
right?
I have one patient that I'm dealing with that diagnosis.
With that diagnosis, right?
Mhm.
And they're usually severe cases that they don't want to deal with.
Mhm.
So they put them in a dumpster. That's
Yeah.
it.
Yep.
And so,
They say go to talk therapy. That's what they tell them.
or they give them psychotropic medications,
Yeah.
like really bad stuff, and they
Yeah.
kind of pile them on, you know? Um, and so she was passing out three, four, five, six times a day. And anxiety was a big trigger for her. Neck movement was a big trigger for her. but any type of emotion that you brought up with her,
Hmm.
she would just collapse
Yeah.
totally, like out. We'd be walking with her, and all of a sudden she's down. She's down.
Yeah.
Um, and
The
so
first thing you think of is a drop seizure, right? And
a
but
drop seizure.
but it's
Uh-huh.
not.
No,
Yeah.
but it was cataplexy,
Yeah.
secondary to a myelopathy.
Yeah.
Um, and so the medical profession, once they diagnosed her, dropped her. Okay. And my questions about sleep were not taken seriously.
Hmm.
So,
Yeah.
um,
Yeah. So sleep will certainly play into that. Um,
well, I thought so. And I keep talking to the parents. No, she sleeps great. She goes to bed, she
yeah.
sleeps great. I don't
Yeah.
believe it. I don't believe that she was getting sufficient sleep. And I thought that was part of the problem. I'm
Yeah.
not saying it would have cured her completely, but
Right.
it would have added a distinct advantage in doing the case.
Hmm.
The other thing is that most of the neurology practices that she had gone to in Ohio um, didn't want to see her again. They wouldn't do advanced MRIs to her
Hmm.
or nothing.
Yeah. Yeah.
So I was able to get an MRI to her, and we saw some spinal ligament damage in the upper cervical, C2, 3, and 4. And
So she had that unsteady atlanto-occipital.
yeah,
Yeah,
didn't
because
have like Chiari or anything like that, right?
yeah, yeah.
So,
I had a patient that's similar to that. One of the things I was ruling out was a vertebral artery insufficiency
mhm,
due to that type of instability at that level. And it's a hard thing to really diagnose, but this guy was having symptoms of just developing these I can't even describe how he described it, but he would just get this feeling like weakness in his lower body and upper body. And at first, when I first met him, I thought, well, maybe he's got a seizure disorder going on,
mhm,
but it's not that. And we're working through this whole algorithm of things that it could be because he's had it for years and nobody, and it came on
mhm,
suddenly. And I said, and I learned this from Carrick. If it's a sudden onset, you think circulatory first. And so, as I'm thinking along that, I'm thinking, gee, I wonder if he has this peculiar syndrome. And I found a YouTube video on this doctor from one of the universities in California talking about it and how it's easily overlooked and missed. And the
right.
test, you have to do a transcranial Doppler and a functional one with head rotation, so on to pick it up. But I know I'm digressing, but I just you kind of sparked a you know
One
uh,
of those many brain
pace
cells you
and
got.
yeah. But so what
Yeah.
happened with this patient of yours?
Well,
That
I mean, I got her an MRI,
yeah,
um, and then I had to discharge her. I mean, I couldn't really do anything more for her. She was passing out all the time. Everything, little thing that we did with her, she passed out. And then the medical profession didn't want to see her.
yeah,
Um, yeah. So, I mean, I would want, I called a neurosurgeon that I knew. And if she had been local, we would have gotten her in Jefferson for some advanced studies to see if we were going down the right track
yeah,
with her.
yeah,
But she's from Ohio, and it was just she couldn't do it.
yeah.
So we sent her back
Wasn't
to Ohio.
yeah, wasn't doable.
Yeah, the doctor I referred her to started using peptides with her. The neck pain went away.
Yeah,
She had considerable neck pain, but she still passes out. And anxiety is a feature of that, right?
yeah.
Um, mhm.
Yeah,
So
and so when you have something like that and there's anxiety, having that condition in and of itself is enough to trigger anxiety, right?
it's
Because
enough to trigger anxiety, right?
you just
Exactly.
don't
Or
know when this is going to happen. When am I going to collapse? And yeah. And these are really tough cases. And, you see a lot of these tough cases that fall through the cracks. And you do such a phenomenal job with them in helping them. But the problem is that these cases are relatively rare that we're dealing with. And so you can't just follow the standard medical algorithm to get to the answer. And this is where your expertise in functional neurology really is a blessing to all of your patients.
well, there's other types of cases,
Yeah.
very frequent now. People that are athletically, like they're marathon runners. I mean, they're athletes in their life,
Mhm.
and they're very accomplished. I like running marathons and half marathons, and they like doing Spartan runs and all kinds of stuff. And then they end up with POTS,
Yeah.
and I mean, they can't get out of bed. They have chronic fatigue. They have all the comorbidities that go along with it: pain, headache, pain, um, and
And it's
dizziness,
counterintuitive. You would think
syncope.
that population would be the least likely to get that.
They'd be more resilient.
Yeah.
And so, over the last, I would say, 4 months, I'm thinking again,
Mhm.
sleep, right? What happened in their training or their overtraining that created bad pathways in the brain, bad
Mhm.
connectivity,
Mhm.
resulted in them losing efficiency in sleep. Okay.
Yeah.
So, we talk about that the maintenance, especially for active people, is sleep, right?
Yeah.
Really?
Yeah.
So if people are going to be working, training, and things like that, then sleep has to be something that they participate in and they take seriously. And I know I am in the practice is taking sleep more seriously. Now, when we do a map or we doing maps um, with BrainMaster, we're looking
Yeah.
at like 6,200 voxels throughout the
Right.
brain, right?
Right.
What are some of the keys that we'd be looking for in the sleep realm?
So, well, first of all, when someone has a sleep issue, what I typically see is number one, there's increased slow activity. So theta, delta. Oftentimes you will see that if you're looking at the surface Z-scored maps for absolute power,
Right.
you're going to usually see this excess theta posteriorly,
Uh-huh.
or it could be posterior and more central. You're also going to see delta activity, which may be more posterior, or it may be right at CZ, right in the bullseye of that intersection between the frontal and parietal lobes. And so that's a pattern that I have typically have seen. Now, also looking at the fast Fourier transform, which is page, if you're looking at the QEEG Pro map, that would be page 3 and 4. And those are showing you where the greatest power in each individual frequency, 1 hertz
Uh-huh.
at a time, is greatest on that scale. Now, normally, the greatest power for delta should be frontally, and the greatest power for alpha, of course, should be posterior. And the greatest power for theta should be frontocentral.
Okay.
So what you'll see in someone who is has a sleep issue, or particularly, this is the other thing that I look at when I'm doing an eyes closed recording. If they're properly rested, they should not get drowsy during that 10-minute recording or whatever you're doing. And the earlier on in that recording that you start seeing those signs of drowsiness,
Hmm.
which would be the slow rolling eye movements, that lateral eye movement going slowly right and left. And you look at F7 and F8, and you see those are going together. They're moving toward each other and away. And then also looking for alpha dropout, because when someone gets more drowsy, alpha just disappears, and it'll
Okay.
disappear for a few seconds, and then you'll see a burst of alpha, and that's when they're becoming more alert again. So if you see that early, the earlier you see that in that recording, the more likely they have something going on with their sleep. So that's another thing I look at. But getting back to the maps, if someone is getting drowsy, and they shouldn't be getting drowsy, if they're chronically sleep deprived, then you're going to see, instead of that maximal power of theta being frontocentral, you're going to see it move to the back. Because when
Right.
we get drowsy, alpha drops out, and then theta starts to climb up and take its place, and then it gradually moves forward. So that's another sign that tells me that I need to see what's going on with their sleep. But as far as the S. Loretta's, I would look at the insula cortex, the anterior cingulate. Those would be really important areas. Mainly because the right insula, anterior insula, is regulating sympathetic drive. And so if you have overactivity, that's going to cause a sleep issue. But you also want to look at the motor areas, because some people have this restless leg syndrome, or this what they call it now, periodic limb movement disorder in their
Right.
sleep. And that's interrupting the stages of their sleep. And they don't even, a lot of times, they don't even know they have it. And this is why I like that, doing something like the sleep image ring and getting that information to correlate all of this together. Uh,
Yeah, I just thought my wife didn't like me. Was mad at me. She kept getting,
she was kicking you, huh? Periodic limb movement disorder. And then you get into the question of hormones and everything else that
yeah, there's
disrupts sleep,
whatever menopause.
right?
I'll get in trouble for all this.
Yeah, and now I'm at home and this cat is wants to sit below. Yeah, talk about sleep. Cats sleep all the time, as you know.
That's right.
Uh, but as far as the neurofeedback applications, the classic one is sensory motor rhythm training, and so that is a thalamocortical loop that is also communicating with the basal ganglia
Hmm.
and the cerebellum. And according to Barry Sturman, who did his research with cats on and discovered sensory motor rhythm, and he said that it can quiet down the red nucleus. So, all of these things can certainly help improve sleep. But regardless of what we do as clinicians, as you know, it's so important for that patient to do what they're supposed to do.
Oh,
And
exactly. Follow up. Yep.
Yeah, well, not only that, but I actually AI assisted, but I came up with this guide to reestablish circadian rhythm. And actually, I'll send it over to you. I'm pretty happy with the way it came out.
Yeah, wonderful.
But the most important thing, according to all the sleep experts, is that you have to get up at the same time every day. Even if you go to bed really late, you got to get up at the same time. That's one of the main anchors. The other thing is within 30 minutes or so of getting up, exposure to bright light. And the best is sunlight outside. So you get up and walk outside.
Right.
But I also have a light box. I have a light box in my office, and I tell my patients to get a light box and make sure that, when you're eating breakfast or reading in the morning or something, they're in front of that bright light that's simulating morning spring sunlight. And
Right.
those are two of the most powerful things you can do. And then, of course, the dimming of the lights an hour or two before you go to bed and all of that. And then there are other things that could be added, but those are the main things. And they have to do that. If the patient is trying to get better sleep, and you give them these instructions, and you can use your neurofeedback and my neurofeedback and whatever else we're doing. That's what's going to really help that effectiveness or efficacy of that modality is for them to follow the instructions to reestablish that normal circadian rhythm. And
Hmm.
and so very, very important for them to do that. Uh, anyway, yeah, so this sleep is a big topic. And I was so happy when you said, we got to talk about sleep because,
Exactly.
we put our heads together and we come up with
We'll come up with some really good
really
stuff.
interesting
Really,
conversation.
really great stuff. Yeah. There's apnea. Most people talk about obstructive sleep apnea, but there's neurological sleep apnea
Yeah,
also,
the central sleep apnea is
central
very
sleep
dangerous.
apnea, right? Now, I think a lot of people have central sleep apnea. That's not
Yeah,
really, they don't take the time to identify it properly. They just give you, throw a CPAP at you, and then
yeah,
off you
yeah.
go. Yeah.
I had a 20, I think she was 21-year-old gal. And this was a long time ago in my chiropractic practice on Staten Island. And she's a very pretty girl, young girl, vibrant. And I forgot what I treated her for, a low back pain or something. She did fine. But I think it was a year or so after I last saw her. And I just decided to call a few patients, as we normally do. How you doing?
Mhm.
See how they're coming along. And I got the mom, and she said, "Oh, she passed away in her sleep." I was like, "Oh my God, what happened?"
Right.
And it was she didn't elaborate, but I'm thinking, oh, that's probably what happened. That central sleep apnea. Um, and they just stopped breathing. And it's scary to think about when you tell patients about this. Then they're like, you're going to give them insomnia because they don't want to go to sleep. They want to make sure they're still breathing.
Yeah.
But it's rare, but it can happen.
Well,
And
they talk about sudden infant death syndrome, right?
yeah, right.
It happens.
Yeah, yeah, goes along with
It's
that.
really kind of the same thing
Hmm.
going forward, right? Um, yeah. So, but that's really kind of like a challenge,
Hmm.
but it's not. It's like when you've been doing this for so long, and you get these experiences. Really, kind of sharing it is just what should be the outcome of all these
Yeah,
years of experience with patients that you have. And
yeah,
and then the more that we get, then we can refine what we're doing so that we can give them the greatest gift, right?
Yeah,
Um,
absolutely.
yeah. So
A good night's sleep is one of life's simple pleasures.
it really is because once you've had one, it's like,
Yeah,
okay, not going to
yeah,
repeat. I mean,
yeah.
that's like,
I mean, you remember going through, as I do, the chiropractic curriculum is so intensive, and you know, and you stay up late and studying and everything. And I think back at what I did, um, in those years, and I'm thinking, if I did it a little differently and got some better sleep,
well,
maybe,
I learned my lesson when I
yeah,
first entered St. Joe
yeah,
and a second semester exams in physics, um, modern physics.
yeah,
Dr. Houston, he was tough. Dr. Houston was like tough. So, I mean, I pulled like all-nighters on my week of my exam. I really wanted to do really well. I'd
yeah,
done really well my first semester, but I really kind of wanted to press everybody.
right, right.
And my last exam was modern physics with Dr. Houston. So it was early, like a 9 o'clock test, and I just stayed up all night and drinking coffee like crazy. I guess I got to the test and I drew a blank, like a
Yeah,
total blank.
that's what it's
I
saying.
couldn't remember anything. And I was
Yeah,
so upset I was going to cry,
yeah,
right?
yeah,
And I handed the test in to him and I said, Doctor, uh, I forgot everything. I forgot everything. He's like looking at me like, yeah, okay. All right.
I'm having a seizure.
Yeah, you're a party or something. Your dad at Kavanaugh's having a few brews.
Right,
I'm like,
right.
no, I'm just telling you. So he flunked me, right?
Yeah,
The second semester in college, and I'm flunking. I'm like, I'm gonna have to get out of physics. I can't do it. Then
yeah,
I said, I'm never gonna lose a night's sleep again, ever.
yeah,
I aced everything else, but I just got totally burnt out, and then I've got all the complicated equations and everything, and I went back to him, and he gave me a D plus. He ended up, he said, "You got a B plus on the midterm. I'll give you a D plus, and I'll believe you for this time, right?" But I remember Dr. Houston saying to me, like, "Okay, it was either you were partying or you lost, you were up all night. So it was either one of those." And so I decided then I would never, I would fall asleep at 11:30,
yeah.
right? And
Mhm.
I would get up at like 6:30, and that was it. I would never, ever, ever stay up and lose my sleep. And I,
Yeah,
sometimes, these lessons can be hard, but they kind of stick with you. And I did that all through chiropractic college also.
yeah.
I had to get my sleep because I knew that I would, if I didn't, I would just totally screw up.
Yeah, that's lesson learned, and I learned that one too the hard way. So, but you think if I just push through,
Yeah.
but
Yeah.
your brain just memory consolidates when you're in slow wave sleep, and if you don't get enough of that, you're not going to remember.
But as a parent, sending my kids to private school
Yeah,
was kind of a big mistake on that level and sleep level because my kids were taking all these honor courses and AP courses. And I'm like, I go to a parent teachers meeting. I said, well, why do you have to cover 5 chapters in a week? Why don't you like learn in one chapter, learn it inside and out, and have them remember it for the rest of their life rather
yeah,
than cramming it in and then losing it
yeah,
because they weren't getting any sleep. My kids were burnt out from high school before they even got to college. And I mean, just with my wife at the time, we just argued about it all the time. They have to do this, and I'm like, you're right. They don't. They don't.
yeah,
They can succeed in life, right? A far better way if they do it in a way in which they learn things. They really learn it. So
yeah,
yeah.
yeah. And, so sleep's a big topic for sure.
Okay.
But getting back to that SMR also, the research shows that the sensory motor rhythm, when you uptrain that with neurofeedback, those individuals will have greater sleep spindle density when they go to sleep. So sleep spindles are going to be seen in stage 2 sleep, and they can get more of that stable sleep. So that's one of the reasons that they attribute that SMR training for helping with people who have insomnia.
Well, it kind of makes sense,
Yeah.
that the brain anticipates,
Yeah.
so the anticipation part of the brain is pretty cool. I mean, I did a podcast on muscle. Muscle is an exocrine and endocrine organ,
Hmm.
and it really does feedback, not neurologically, but chemically with the brain and your liver, your pancreas, and
Hmm.
different organs in the body. And it really, it's telling the brain that I'm really active. I mean, I'm active. I mean, I'm working really hard. Can you give me some sleep later? That's really what the question is, right?
Yeah.
You know,
Yeah.
um,
That's
and so it's a muscle memory, right?
hmm
That really boosts your autonomic nervous system,
Yeah.
sympathetic, and not only your sympathetic, but your parasympathetic. Because your parasympathetic is screaming, balance me out, sympathetic system. Give me a chance to come back,
hmm
sympathetic system.
Yeah.
Right. So that's an activity that you're right. I think that as you are active and working and doing things throughout the day, um, your body says, okay, anticipate that I'm going to need to rest.
Yeah.
And I think the buildup of spindles is one way that it's doing it, the sleep spindles.
Yeah.
Yeah.
Yeah. It's so the thing I talk about with my patients when I go over brain maps and things with them is I tell them that when I do a follow-up brain map, it's not that I want everything to match the mean. That's not the goal. What I want to see is change, because the underlying problem, and if you think about it in probably just about anything that any type of patient we're working with, neurologically or otherwise, there has to be this dynamic range. And when there is an underlying condition, whether it's insomnia or it is anxiety or whatever, there, I tell my patients, your brain is stuck in this pattern. And what I want to see is that brain get unstuck. Once it's unstuck and it has that dynamic range and that flexibility, then everything is going to be functioning that much better. And that goes back to what you were talking about, even with, muscles feeding back and so on. If they get stuck in this activity kind of mode, you're going to have a restless night's sleep. So reestablishing that dynamic range is one of my primary goals
Right.
when I approach a patient.
Well, Doc, we spent like 50 some minutes already on this
Wow,
podcast,
time
right?
flies. We can
Time
go on
flies.
another few hours if you want.
Yeah, so a couple weeks. Okay,
Yeah,
let's revisit it on a different level.
sure.
You go back and think about it. Think about cases that you had in the past that you haven't thought about in a while, and
Yeah,
then, we'll do another one. All right, and keep advancing this knowledge of sleep and its the ability for health maintenance. Okay.
yeah, yeah, absolutely. And let's encourage all our patients to follow the rules to establish circadian rhythm.
Circadian rhythm. All right.